Okay, welcome back. Hi, everyone. Good evening. I'm back again with maternity nursing, and I am continuing the series on postpartum period. Today, the topic is going to be postpartum period. Let me just go ahead and share my screen, and then we can start talking about postpartum period. So if you can see my screen, this is postpartum period and exactly what you expect to see. So postpartum period is the period when the reproductive tract returns back to its normal non-pregnant state. Postpartum is when the uterus returns back to its normal non-pregnant period. And this period starts immediately after childbirth, and it's usually within 6 weeks. So usually the period to have the uterus go back to its normal non-pregnant state takes about up to 6 weeks. 6 weeks after delivery. So there are physiological changes, and looking at the diagram I sent, you would see that it's a diagram explaining how the uterus returned back to its normal stage, how the uterus gradually go back, starting from day 1 after delivery. Let me just magnify it a little bit for your view. So starting from day 1, you see the fundal height immediately after delivery, it starts coming down. So this is a normal and what is expected immediately after delivery. So the involution is a rapid decrease in the size of the uterus as it returns back to its non-pregnant state. It's a period that you have the uterus gradually return to its size, normal size. So clients who breastfeed may experience more rapid, or they will experience a quicker involution than those who do not breastfeed, because breast milk or production of breast milk will involve the release of oxytocin. So when a child is breastfeeding, oxytocin is released, and this is what happens with breast milk. So it will cause the uterus to go back to its normal state faster. It will cause the uterus to go back to its normal state faster than the mother who is not breastfeeding. Now let's talk about assessment. So assessment, when you are assessing a postpartum mother, what do you look out for? So the weight of the uterus will decrease from approximately 2 pounds to 2 ounces in 6 weeks. From 2 pounds to 2 ounces in 6 weeks. So, and the 2 pounds is about 900 grams. If you remember the beginning of the maternity nursing, I had mentioned that the uterus, up to the level of delivery, the uterus gets bigger and the weight increases up to 900 grams. That is about 2 pounds of the uterus. And it returns to 2 ounces, which is 57 grams in 6 weeks. So the endometrium regenerates, the fundus steadily descends into the pelvis, and then fundal height will decrease by 1 centimeter each day after delivery. So for each 1 day after delivery, by 10 days postpartum, the uterus cannot be palpated abdominally. So when you try to palpate the uterus 10 days after delivery, you cannot palpate it anymore. It has gone back as an abdominal organ. You can no longer feel it. So it becomes flaccid. You expect to have a flaccid fundus, which indicates uterine atony and should be massaged until it's firm. So when you have a flaccid fundus, when your uterus is still flaccid and you are able to palpate and feel it, and it's firm, you have to massage it until it becomes firm and tender. So, but this one also increases infection. It also indicates infection. So when you have a tender, firm uterus, a tender, firm uterus. It will show that there is infection. So approximately by 10 days, you shouldn't palpate to feel anything. But if at that time you can still feel it and it's tender and firm in the pelvis or in the lower abdomen, then it indicates there's possibly infection. You want to do a workup for that. So after pains will decrease in frequency after the first few days, that's after delivery, there will be pain, but that pain will decrease. It will gradually go away after 10 days. So let me talk about the uterine involution on this diagram that we see. So the first day of delivery, can we see the position? So at delivery, when a woman is in labor or at the time of delivery, this is where the fundal height is at. This is what you expect. Remember, I had shown you a picture of the week by week growth of the baby in the stomach or in the womb. So when the baby is in the womb, the week by week growth up to 37 weeks and 40 weeks of delivery, when it starts reducing in size, where it raises above the symphysis pubis, 12 weeks, 24 weeks, and then it goes up higher all the way until it becomes like big. So after delivery, it starts coming down. When you measure the fundal height, you expect to see a lesser number from when the mother was 30 or 27, 28 weeks. You expect it to start coming down that way. And after 10 days, it goes back to its normal size. You can no longer feel it. So 9 days, 10 days, it is born as an abdominal organ. So the return of the uterus to its pre-pregnancy size and condition begins immediately after expulsion of the placenta. Remember, delivery includes placenta, but that is after the child is born. Then you now deliver the placenta. So the fundal descent will immediately after birth in the uterus will be at midline, 2 centimeters above, 2 centimeters below the level of the umbilicus, and it will be at the size of a grapefruit, like 16 weeks of gestation. So that's the height. So usually you see the woman still looking pregnant after delivery, but it's going to go down. So the total weight it gets is up to 1,900 to 1,000 grams of the uterus that I had mentioned. And within 12 hours, the fundus may be approximately 1 centimeter above the umbilicus, maybe approximately 1 centimeter above the umbilicus. This is the umbilicus. So within 2 hours, within 12 hours of the delivery. So during the next day, the next few days, the fundus descend to 1 to 2 centimeters, that is finger breadth, every 24 hours. So by the 6th postpartum day, the fundus is normally located halfway between the umbilicus and the symphysis pubis. This is it. You can trace it all the way down here to the 6th day. So a week after birth, the uterus once again lies in the true pelvis. That's the week is going to be 7 days. It goes back and lie in the true pelvis. So after 9 days, 10 days, the uterus should not be palpable. Should not be palpable abdominally. So if you're able to palpate it and it's tender and firm, there is infection. Let's talk about lochia. Lochia. So lochia is discharge from the uterus that consists of blood from the vessels of the placenta site and debris from the decidual. Debris from the decidual. So this is what lochia is. When you are assessing lochia, we have how lochia should look. So we have different types of lochia. We have the rubria. It starts with the lubria. And the lubria is bright red discharge that occurs from the day of birth to 3 days. So the first 3 days of delivery is rubria. The discharges that come is lubria. And that one is from the one immediately after delivery to It's giving me this way. From day 1 to 3 days, and is what is bright red color. Look more bloody. So the next one that a woman will have is serosa. Serosa. Let's talk about serosa. Serosa. And this one is brownish pink discharges. Brownish pink discharges, and it's from day 4 days to 10 days. Okay, so remember, rubria is the first discharges a woman will have. Serosa is the next one, and this one is bright red color, usually 1 to 3 days. Serosa is brownish pink, and it's 4 to 10 days after delivery. Let's talk about alba. Alba is white discharges, and this one will occur from the 11th to 14 days after delivery. All these things happen after childbirth. Okay, so we have the lochia in 3 types. We have the rubria, serosa, and alba, and 14 days. So discharges should not smell like normal menstrual flow. All these discharges, you don't expect it to have a flow, a smell like the normal menstrual flow. It decreases daily in amount and in quantity. It decreases daily. So discharge may increase with ambulation. When the mother is walking, the discharge may come more. Now let's talk about the cervix. We have cervical involution, and this one occurs as the muscles begin to regenerate after 1 week of birth. Let's look at the vagina. These are the structures involved in childbirth. So the vagina will, the vagina is a distinct, or vagina will gradually decrease, although the muscle tone is never restored completely to the pre-gravid state. So the vagina will kind of feel distended, and it will gradually decrease in muscle tone. The elasticity of it will decrease, but it takes time. It doesn't just go back to its pre-pregnancy state right away. We have the ovarian and menstruation, ovarian function and menstruation. So we have ovarian function, which depends on the rapidity with which pituitary function is restored. So menstrual flow will usually begin 1 to 2 months after childbirth in a non-breastfeeding mother. So if the mother is not breastfeeding 1 to 2 months, they should expect to get their normal flow. But usually if the mother is breastfeeding, it delays the ovulation period. It delays menstrual period. So usually it will take 3 to 6 months before they start having their normal period. That is in breastfeeding mothers. So women may ovulate without menstruating. That's why some people, before they know you are pregnant. So some newly delivered mothers may ovulate without getting their menstrual period. So breastfeeding should not be considered a form of birth control. So do not be deceived. You cannot use breastfeeding as a form of birth control, because sometimes when you are breastfeeding, you will ovulate, but you will not get menstrual flow. You will not get menstrual flow. Let's look at the breast. The breast will continue to secrete colostrum for the first 48 to 72 hours after birth. The colostrum is a clear liquid that will be secreted. It's clear brownish, that will be secreted. I'll just use clear. Then that's what the baby needs. It has a lot of antibodies in it. The baby needs that to gain some immunity. It has a lot of nutrients in it. It doesn't come plenty in the first day, but the baby is enough. The baby is satisfied with the clear liquid that come out. And that's the first yellowish liquid that the mother will have. Now, urinary tract, the urinary tract after delivery. So the client may have urinary retention as a result of loss of elasticity and the tone and loss of sensation in the bladder from trauma, medications, anesthesia, and lack of privacy. So this is what happened to the urinary tract system after childbirth. Let's look at the GI system. We know childbirth affects all other systems because it affects the whole thing about mommy. So the client will usually be hungry after birth. It's a lot of energy that is used. So mommy will be hungry. There'll be constipation that can occur with bowel movement. So for constipation, we have soft forms too by the second or third day of delivery. Hemorrhoids are common with mothers who just have a baby. Excuse me. It is common to have hemorrhoids. So in the breastfeeding mother or in the newly delivered mother, they encourage them to walk. And they encourage them to report how many times they have been to the bathroom to pee or to move their bowel. Now, if you are constipated, you have to report it. So that is the expectations. And then they want to continue monitoring their vital signs as often as they can. So postpartum interventions, what will you do for a mother who just gave birth? You want to monitor their vital signs. You want to assess their pain. Remember I said they are in pain for a couple of weeks. So it takes like about 3-4 days and the pain starts subsiding. So you assess their height, you assess the height, consistency, and location of the fundus. You want to monitor this to make sure it is reducing in order. You want to monitor it from day 1, 2, 3, up to 9 and 10 to make sure that you can no longer feel it. But remember, all these days, if everything is fine with the mother after delivery, they would have gone home. So you just want to educate the mother in case after 10 days they still feel their stomach tender and firm and they're having a fever, they're not comfortable, they still have a pain, they want to come back. So you monitor for perineal laceration. Some people get a laceration when they're about to give birth. They have to do episiotomy. They have to manually cut the vagina to make space for the baby. Others will also get natural tears from the baby just pushing its way out. So we have another problem that can happen with the postpartum intervention that you, the nurse, want to monitor is breast engorgement. Breast engorgement, and then you want to monitor for pain with the breast engorgement. So you want to teach the mothers how to manage breast engorgement. Now, bowel status, I already mentioned this. Encourage them to frequently go to the bathroom. You encourage them to walk. You encourage them to do exercise. You encourage them to report any warm feeling or tenderness on their legs. This can be a sign of thrombophlebitis. So you also want to administer RhoGAM if prescribed for mothers within 72 hours postpartum to Rh negative mothers who has given birth to Rh positive newborns. So if the baby is Rh positive and mommy is negative, the mother has to get RhoGAM, and that is given within 72 hours after delivery. So mark you, this is a possible question for the NCLEX. They want to know if you understand that RhoGAM should be given at 72 hours after delivery if the baby is Rh positive and mommy is negative, or mommy is negative and baby is positive, whichever way around. So you also want to evaluate rubella immunity if immune, administer rubella to the mother. You assess with the newborn, you assess emotional status, client teaching. You want to demonstrate the newborn care skills as necessary. You want to try to provide the opportunity for the client to bath the newborn. So you want to teach mommy what to do for this baby at home, because that's a new baby, especially if it's a new or a first-time mother who has never bathed a child. you want to see their coping skills with the baby. So you want to make sure that psychologically the mother is not traumatized that they cannot care for their child. So let's talk about postpartum discomfort. There is pain. So some mothers will have pain immediately after delivery, and this pain will occur because the mother had a lot of contractions of the uterus. So they will have postpartum pain. So you also want to help them with that management of pain. They usually give some painkillers, anti-inflammatory pain medications, or some and strong analgesics like opioids, depending on the situation and depending on the mother and how much pain they're having. So we have the perineal discomfort. Of course, the baby just came out of your vagina. So there will be pain and discomfort around the vagina area. So after the first 24 hours, you want to apply warm seat baths. But the first 24 hours of delivery, you want to give cold packs. You want to help reduce swelling. So you put ice pack to the vagina area to reduce swelling. But after 24 hours, you want to give warm seat baths to help with healing. Then we have episiotomy. Episiotomy, I had mentioned that already. This is when they had to cut the client. So you want to check for their urine immediately after episiotomy. Sometimes they have to suture it because it's so big. And if the suture, you want to make sure they didn't suture the urethra opening. The client is still able to pee. So you want to administer pain medications as well. We have perineal laceration. Perineal laceration. So care for an episiotomy is, perineal laceration is just what they do with the episiotomy. Episiotomy is if the client needs to be cut and all of that. But the perineal laceration is when it has to be cut to have the baby come out. So you give rectal suppository and enemas, which may be contraindicated to avoid injuries to the sutures. So for a mother who had perineal laceration, the suture you might think that maybe if you give enema, it will help with the constipation, but no, you don't give this patient enema. You don't give them enema, and you don't give them rectal suppository. You don't want to bother that side of their body. You want to encourage warm seat bath after 24 hours. And breast engorgement and discomfort, you encourage them to wear supportive brassiere, supportive bra. That will help with the engorgement. You want to also encourage them to use ice packs between feedings of the baby if the client is non-breastfeeding. So if the client is not often not to breastfeed their baby, you want them to use ice pack. Take note. But if the woman is breastfeeding, they use warm pack. So if I am breastfeeding, you want me to take warm pack. It will help the milk to flow out. But if I am not breastfeeding, then you want it to go back. So you don't want the milk to start flowing out and it will be messing up everything. So you give them cold pack. That's how you help with breast engorgement. You administer pain medication and it gradually goes back to its normal state. Now, constipation. So with the engorgement, when you give the hot pack, it might help the milk excrete. It might have the mother like expel a lot of milk. So if for some one reason the baby have not learned to latch well with the breast yet, you can encourage the mother to pump the breast out. But the best is to have the baby hold the breast to breastfeed. So you don't say because of the engorgement the baby cannot breastfeed. Baby can still breastfeed with engorgement. The constipation, you want to encourage them to take fluid up to 2,000 liters per day. You want to give them stool softness. For most mothers, newly born mothers, they get stool softness. Now, emotional changes. So you want to acknowledge the feelings and you have to be caring as well to the mothers. You want to determine the availability of family support and systems and resources that the woman might be in need of. Remember, postpartum depression is a key factor when you are thinking of the woman going home by herself. You want to question whether they have some support system, they have a supporting family, loving people who will be there to help them, because in the initial stages after delivery, it is stressful. The mother can get burnout and they start getting depressed. A client should be assessed for depression, like I just said. So you want to assess them for depression, psychological support during the pregnancy and the postpartum period. You need to assess for depression. Now, nutritional counseling, you want to discuss the calorie intake with breastfeeding. I discussed this in the previous video when I spoke about how much calorie a pregnant woman should take and how much calorie a breastfeeding mother should take. So a breastfeeding mother should take more to be able to share with the baby, and a pregnant mother should take more and also share with the baby. But most of the caloric need in the breastfeeding mother is usually a little bit more than the pregnant woman. So you have to encourage them, if they are breastfeeding, to increase their calorie need by 200 to 500 calories per day. So if I was pregnant and I was eating this and now I'm breastfeeding, I need to increase it from 200 to 500 calories per day. So for breastfeeding, what are you supposed to do? So you want to help the mother, especially as soon as the newborn is out. You want to help them on the delivery table if it is possible, to have the mother hold the child to themselves, place them on their abdomen in between their breasts and have them hold on to them. This is to encourage bonding. And then you want to stay with the client each time he or she want to nurse the baby. You want to see how they are doing. You want to assess if the latching is well done, if the baby is able to latch well to the mother's breast, so, and the comfort of the mother. So you want to hold on to see how it goes. So uterine cramping may also occur on the first day after birth while the client is nursing. So when oxytocin stimulation causes the uterus to contract, you want to explain to the mother that immediately after birth, they are breastfeeding and they have cramps. You want to tell them that this is not unexpected, it is expected, because on the first day after delivery, the uterus cramps. So once it's cramping and you are breastfeeding, it is helping with involution as well. That's why the involution mothers, their uterus can go back faster than those who are not breastfeeding. So if engorgement occurs, you also teach them about the engorgement, warm pack if they are breastfeeding because they want more breast to come, and cold pack if they are not breastfeeding. So the client should not use soap on the breast because it tends to remove natural oils. So you educate the mother, no soap on your breast, your nipples especially. So if there are cracked nipples that develop, the client should expose the nipple to air for 10 to 20 minutes after feeding. So after you finish feeding, expose the nipple to air for at least 10 to 20 minutes after each breastfeeding moment of the child. You also want to make sure they are aware to increase their caloric need, 200 to 500 a day. So those are the things you want to teach a breastfeeding mother. So now, I just want to talk about the amount of the lochia. I had spoken about it, but I didn't go into details about the amount of the lochia that is needed. So the scant one, we have the amount of lochia. We have scanty lochia. These are problems that you do not expect. At least the ones I described was just the normal colors of the lochia and the name. So we have the scanty lochia, we have the light one, we have the moderate and the heavy and excessive. So the scant lochia will be less than 2.5 centimeters on the menstrual pad. So when a patient put on the menstrual pad on the first day after delivery, they'll have something small, just like one inch, less than 1 inch will be touched on the pad. I don't want to use diaper. Grown-ups, no grown-up want to hear diaper. So you'll see a little bit on it. It's about 1 inch. But for the light one, it will be less than 10 centimeters. It will be like less than 4 inches on a menstrual pad in 1 hour. So the scant one, within 1 hour, it will be less than 1 inch. The light one, less than 1 hour, it will be less than 4 inches. We have the moderate, that will be less than 15 centimeters. That's 6 inches on menstrual pad in 1 hour. Now the heavy one will be saturated pad in 1 hour. Saturated pad in 1 hour. Now this will not be unexpected on the first day, but it will be it will be a cause for concern if after second, third day, the woman still get it like that. So excessive pad saturation in 15 minutes is a serious problem to monitor right now. You cannot wait because it's low key. Now let's talk about care for the non-breastfeeding mothers. So if a mother is not breastfeeding, how do you care for this woman? So for a woman who is not breastfeeding, you want to tell them to avoid stimulating the nipple. Don't let them sit down, they are using their finger touching on the nipple. They have to avoid stimulating it. They want to apply breast binder, wear a well-fitting bra, and apply ice packs. I had mentioned that already. And they should also take mild analgesics for the engorgement. So engorgement will usually resolve within 24 to 36 hours after it begins for those who are not breastfeeding. 24 to 36 hours for those mothers who are not breastfeeding. So let's look at the normal postpartum vital signs. So the normal postpartum vital signs, normal postpartum vital signs. So let's talk about the temperature. So the temperature may increase to 100.4 during the first 24 hours postpartum because of dehydration and the effects of labor. Anything higher may be caused by an infection. So if it's above 100.4, it is a cause for concern. We have the pulses. The pulses of the mother may decrease to 50 beats per minute. So mommy may get pulse lower. The mommy may get bradycardia, bradycardia. This is expected. So pulse greater than 100 beats per minute will indicate excessive blood loss or an infection. You don't want it to be too high as well. Blood pressure should be normal. Suspect hypovolemia if it is decreased. So you have the patient after delivery, the blood pressure decrease, you want to suspect hypovolemia. Then respirations, there's rare change, not significant. If respirations decrease significantly, you want to suspect pulmonary embolism, uterine atony, or hemorrhage. So these are practical things you will see in a mother who has just finished delivering. Now, the next thing that you want to see are signs of emotional changes. You will see that the mother will have anxiety, the mother will be angry, the mother will be crying. These are signs that tell you that the mother is probably going to have postpartum challenges. So there'll be fatigue, headache, insomnia, restlessness. You see they look sad. Now, postpartum depression, a patient will present with anxiety, appetite changes, they will be crying, they will also have difficulty concentrating or making decisions for themselves. You're asking them, what's your plan for family planning? And they don't know what to tell you. They will not have energy, suicidal thoughts, and lots of pleasure in normal activities. They will not even, we have mothers that don't even want to take the child. Postpartum psychosis, this is also a problem. Postpartum psychosis, the signs that the mother will have is break with reality. The mother starts acting out. Confusion, delirium, hallucinations, the mother will be panicking, and there will be delusions. This is postpartum psychosis, confusion, delirium, and there will be panic as well. Now, breastfeeding procedure for the mother. You want to wash your hands first. Remember, these are drag and drop stuff. They can ask you. So you wash hands and assume a comfortable position, number one. You want to start the breast with which the last feeding ended. So if the last time the baby finished with right breast, now coming back to breastfeed, I will use the left one first because the baby ended up on the right breast. So the left breast was not tackled, and that's what you want to start with. You want to brush the newborn's lower lip with the nipple. You brush their lower lip with the nipple. You want to tickle the lips to have the newborn open their mouth wide. Remember, that's their communication. You cannot talk to them to listen. So you encourage the newborn to nurse on each breast for 15 to 20 minutes. So on each breast, 15 to 20 minutes, you move them to another breast. So after the newborn has nursed, you want to release suction by depressing the newborn's chin or inserting a clean finger into the newborn's mouth. Don't just have them pull it out. They will pull it out and suck it out, and the mother will have pain. So you want to burp them after they breastfeed. After each breastfeeding, you burp them. Repeat the procedure on the second breast until the newborn stops nursing. You want to proceed and continue after they stop nursing. Then you burp them again anytime you finish breastfeeding them. Then you want to listen for audible suckling or sucking and swallowing. If you hear it tells you they are just swallowing air. They are not actually eating good stuff. It's not that it's too sweet that they are just doing. If you keep hearing that sound, it tells you they are just swallowing air. So these are some of the problems with postpartum period, or these are some of the things we want to take notice of in the postpartum period of the mother. So the woman from head to toe, the lochia, you want to monitor, you want to make sure the uterus is coming down. After 10 days, you shouldn't feel it. You start feeling it 10 days, then it shows there's an infection somewhere. So you want to take notice of that. So on this note, this brings me to the end of postpartum period. Postpartum period is ended. I have postpartum complications to talk about, and I have the newborn care to talk about in maternity, and then we complete that lesson and that chapter. So watch out for postpartum complication video. I will get back to you and then we continue it. Thank you so much for your time, and remember to have a good day. Okay, repeat the video as much as you want. Remember, these are content review. This is not questions for NCLEX. This is content review, and the content is the core foundation. You need to know this stuff, and then use critical thinking to pass that exam. Okay, thank you so much. Goodbye for now.